Hello, my name is Seth Oliveira. I'm the Director of Functional Neurosurgery at the Providence Brain and Spine Institute. I also work for the Oregon Clinic Neurosurgery and Spine. This video is designed to educate you on the procedure called deep brain stimulation and what you can expect before, during, and after surgery. We will, of course, discuss all of this in further detail during your in-person appointment. To begin, let's talk about the procedure. Deep brain stimulation, or DBS, is an FDA-approved surgical procedure for several different neurologic disorders, including Parkinson's disease, essential tremor, dystonia, and epilepsy. Deep brain stimulation is non-ablative, meaning that it's intended to alter the activity of the malfunctioning brain circuitry. Because DBS does not damage the brain, it is adjustable and reversible. It does, however, require an implantable device, which we'll talk about in more detail later. In contrast, an ablative procedure like focused ultrasound intentionally burns these areas to create a beneficial lesion. While these procedures do not require an implant, the effects are fixed and irreversible. It is important to note that deep brain stimulation is not considered curative. Many of the movement disorders we treat with DBS have a progressive nature, and they often continue to progress despite intervention. Despite this, DBS can be very beneficial for many of the symptoms. Generally, DBS is not considered a first-line treatment and is only recommended for patients whose conditions are not helped by medication alone. Deep brain stimulation can create a dramatic improvement in your quality of life. It is, however, one of the few elective brain surgeries, so the risks must be carefully considered. There are three types of risks with DBS surgery. The most common risk is infection at the incision sites. A superficial infection can very quickly spread to the implanted device and hardware, so we must be very cautious and protective of the incisions. The second risk is related to the electrical stimulation from the implanted device. Patients may experience tingling, numbness, muscle contraction, worsening balance, and speech or mood problems. Most of these issues are transient and reversible and can be addressed by adjusting the settings on the implant in clinic or in some cases over the phone. The third risk category involves serious complications such as brain hemorrhage, stroke, seizure, or brain infection. Thankfully, these serious complications are exceedingly rare, occurring less than 1% of the time. Now that you understand more about the DBS procedure, let's talk about the actual surgery and what to expect. The first step is to determine if you are a good candidate for DBS. In addition to a detailed examination and discussion of your medical history, you'll typically have an MRI scan. Depending on the individual, other tests may include neuropsychological tests, physical, occupational, or speech therapy, or other referrals such as psychiatry. These evaluations are tailored to the individual to help us do the best job of predicting your response to DBS and any potential problems you may have related to the surgery. Once this evaluation is complete, the neurologist and the neurosurgeon work together to discuss your case in detail to determine if you're a good candidate for deep brain stimulation. There are two stages to the procedure. Part 1 is the implantation of a thin electrode in the brain. Part 2 is the wiring up of those electrodes to the neurostimulator, which involves passing the electrodes under the skin behind the ear and down to the chest, usually below the collarbone. In most cases, both stages are performed as one single surgery, though there are exceptions. Every surgeon has a slightly different method of approaching deep brain stimulation. My approach is a combination of strategies developed over many years performing these procedures. Before the surgery begins, a trajectory for the electrode is mapped out on a high-resolution MRI. This allows me to guide the electrodes through the brain without causing any neurologic problems. The surgery is performed with the patient under general anesthesia. We perform the implantation of the neurostimulator first, running the cables under the skin behind the ear to the device in the chest. We then turn our attention to the brain electrodes. We open incisions in the scalp along the carefully selected trajectory on each side of the head, and then drill small holes through the skull. The electrodes pass through the brain to the predetermined location and are secured in place. In the past, we have used head frames to guide the electrodes, but now have transitioned to a high-precision robotic guidance system. We then do a CT scan in the operating room to ensure that we are happy with the placement and that the electrodes are implanted very accurately within the brain. The gold standard for testing the electrode's effect on a patient is to perform awake testing during the surgery. We have, however, transitioned away from this strategy due to the understandable anxiety this provokes in patients. Advancements in imaging technology have allowed us to develop a simple sleep testing technique that provides the most essential information about the electrode's placement and its effect on the patient. We studied and published our ability to detect sensory and motor side effects under general anesthesia and demonstrated that we saw no significant difference in patient outcomes compared to our awake surgeries. Lastly, once we are confident in the position of the DBS electrodes, we connect them to the extension cables we placed at the beginning of the operation, then close the incisions with sutures. This X-ray shows what the completed surgery looks like. Typically, the scars are not particularly noticeable. The scalp incision is usually hidden above the hairline, and the chest incision is unobtrusive. Some DBS patients have bumps underneath their skin, but we make every effort to minimize the prominence of the hardware under the scalp. The device will not be activated until 3 to 4 weeks post-surgery. This allows time for slight swelling and fluid around the electrodes to subside. You will visit your neurologist in clinic to have the system activated and the initial adjustments made. Typically, it takes a few sessions to find the ideal settings, but patients will often notice benefit as soon as it's activated. You can return to most, if not all, of your usual activities after surgery. It is important, however, to use caution around big magnets and high voltage machinery. The most common concern is an MRI machine. In this case, you would need to have the device put into MRI safe mode. Thank you for joining me for this overview of deep brain stimulation. Again, all this will be discussed in further detail during your in-person appointment. We'll also be happy to answer any questions that you might have.